AI for personal health optimization. And joining Kennedy up on stage is going to be James Yurkovich again. Also, we've invited Deepak Saini to come, and the conversation is going to be led by Damien Adam. So, welcome everybody.
So, thank you for your contributions earlier today. So we've just heard about Kennedy and James talking about the role of data and how AI and data really are reshaping the future of healthcare. Right now, I want to really talk about what happens when all of this power that AI gives us ends up in your pocket, and people have now the ability to really take care of their own healthcare journey, and what are some of the dangers associated with that. So first, to just kind of set the stage, I want to get James' opinion on what exactly is, an AI pocket coach, or what does that mean to you?
Yeah, absolutely. So it's a great question, because that's where we're headed with all of this. When you and I were discussing earlier, you mentioned that it doesn't really matter what wearable app you use, they all have some sort of AI built in, right? So I think the first key is education. Even as somebody who does this for a living and really dives into the research side of it, it's still challenging for me to look at my own activity data, for example, and know, what does it really mean if I spend this many minutes in zone 5 versus zone 3? What's good for me? Even as somebody who does this and dips my toe into exercise physiology, there's still too much out there for any one person to learn. So a huge part of it is simply going to be the education aspect of having an AI that can very clearly communicate to me what it is that I'm looking at. If it's a chart, if it's a number, whatever it is, I think the education is one key part of it. And another is something that we were just chatting about, Deepak, right before we came out, was the visualization can be really key for just facilitating the interpretation of this. And so when I think about an AI that's going to help me on my own health journey, it's going to educate me to all of these things that I can't possibly learn and know about myself to any kind of expert level. It's going to easily help me interpret, whatever data that I am looking at, so that by the time it gives me a personalized action plan, I'm equipped with what I need to go on my first steps to actually following through on that.
Right, and I think that's important to think about in terms of what the role of that pocket coach really is, and it's, I think, more about providing support and recommendations based on data rather than providing a diagnostic or something more concrete. And with that said, I want to speak a little bit about the challenges and the dangers of having that in your pocket, right? So Deepak, this one is really for you. So we're seeing people really dump medical records into ChatGPT and things like that, right? And getting their own diagnosis and thinking they don't necessarily need the doctors anymore, right? So what is your take on that?
It's a fantastic point, and thank you for having me on the panel. So let's look at the AI as one paradigm which is shifting our thought process. So he talked about AI allowing you to understand your health. So it's like you put your AI pocket coach in your health. That's trying to tell me about me. But the second aspect is AI, which is going to help me in clinical decision making. So two types of interfaces which you're looking at. One is a personalized one, and one is a clinical decision making. I think we are still far away from the clinical decision making AI tools, because that requires a human in the loop. You need somebody who is a clinician to actually confirm what the AI is trying to tell you and if it's right or not. But to get to that level at AI to actually help you clinical decision making, you need a lot of raw data to be fed into this platform. Now, when you talk about data, it comes from my physiology. And as he mentioned in his talk, you need to feed in a lot of data to train these models.
Right.
And if you do not have a lot of data, we cannot extrapolate data from ABC sources and integrate under one umbrella. It's going to have a lot of hallucinations, a lot of data-based predictions, which actually may not be relevant to that particular population. Now, the next aspect is our AI data, which we are using for clinical decision making, is it linked to geotagging? Is it really relevant to me, where I come from, in terms of environment and exposome? So we need to reach that level of maturity for AI for healthcare to actually say the decision-making process is relevant or reliable. We hear about chat, you mentioned about ChatGPT being trying to cure things. We hear about things which worked because, say, ChatGPT detected something, it worked great. We never get to hear what did not work. And that could be in a trillion times more than what worked. So yes, there are opportunities, but I think right now we're in very early stages, which needs still a lot of good quality data to train AI models.
Yeah, I think that's a really good point that obviously was mentioned earlier in the sessions, that the data that we have now is not representative of the population on a global scale. So we have to be careful how we interpret that data that comes out. And we'll talk actually a little bit more about the imbalance of the data and how we can find solutions in Mauritius to deliver better insights to people. But Kennedy, I just want to understand you mentioned this in your talk. I want to understand just how important is having a human in that loop, because there's one thing where we can go directly as consumers to AI with our own medical data, but there's also another way to eliminate humans from the loop, which would be in a clinical controlled setting to remove humans from the loop. But I also don't think that's necessarily a good point. And you talked to that.
No, I don't think it's a good idea to remove humans at all. And especially, I mean, we're building our AI system specifically so that a human will always have to be in the loop to update the results of any testing that's done using our systems, the results of any hypotheses, any new genomic or transcriptomic data. And so that all feeds in the system and makes it smarter as well. And then the human also can ground the rules that the system is operating on in truth and make sure that it's accurate as well. We're barely using an LLM in our AI system, actually. And so it's pretty essential for us to have an actual scientist like using our co-scientist to update its rules. And that's a way that we can have a lot more accurate health and medicine help in the clinic, and we're not really replacing people. So
right. So it's kind of a way to ensure that the insights that are coming from AI are grounded in truth and and really useful for people. Now, how does the physician, the doctor, or the person who's really in that loop have to transform or evolve to be able to work in partnership with AI, because it's quite different from the original workflow. And I mean, that's anyone can grab this one, but
maybe I can take a call at that. I think there's a fantastic slide he presented out there, which is beautiful, and because I really like the way he's put the things together. So there's some biochemical parameters which clinicians love to take. Then you take some imaging data, and then you look at the physical features of the individuals from wearables or actual recordings, and then you integrate them to take a call what exactly is wrong. To think about it from a person perspective who walks into a clinic, I don't have their longitudinal data. I have the data or access to that individual then when he walks into the clinic. So a lot of my AI is now going to depend on what can I do with that individual once he walks into the clinic. What are the features I can extract? And sometimes the features which we can extract are time dependent because I don't have the luxury of spending a lot of time. So that means the number of features which I can extract is minimal. And that's what AI can help us to understand what are the features which we can immediately look into, assess, integrate, and take a call about what could be the potential reason of that person's visit to the clinic. I think that's where the AI will really simplify. Many times when we do the clinical testing, I mean, all of us send our blood reports, we do a battery of tests, and half the time we just turn the pages and we just are looking for something which is bold, underlined, or in red to figure out what's wrong with us. But the question is, do we really need all those tests to take a clinical decision making? Can AI help reduce the number of tests which needs to be done by multimodal testing and figure out what's the fastest way to take a decision on that particular individual? That's where the maximum impact of AI might be. I mean, you can correct me if I'm wrong there.
No, absolutely. And I would build on that by saying that I think another kind of next step on that, and it's more on the onus is on us as building the AI tools, is to program in explainability. So a word that I use a lot when I give like very technical talks is explainable artificial intelligence, XAI, right? This is something that DARPA for the Department of Defense in the US, it's a term they invented back in the late 90s, early 2000s. And basically the idea is instead of just having a black box where data comes in and an answer comes out, I'm not a medical doctor, but I wouldn't want my physician using a black box to make a decision where it can't explain why. And so that's a huge emphasis of everything that we're doing, and I'm sure, Kennedy, you would say the same thing. You know, when we use our knowledge graphs approach, one of the reasons that we talk about knowledge graphs, and we didn't really coordinate on that, you know, that's kind of the cutting edge of where we are in this field, is we use these graph approaches because they provide the opportunity for explainability. So in other words, if I'm suggesting, hey, based on this profile, maybe it's a blood panel with some medical imaging and then some, you know, free text doctor's notes, this is the recommended plan. It's not just giving me the plan, it's saying, okay, well, why is this the plan? And I think that's where, again, we're not replacing any physicians. We still need people who are extensively trained in practicing medicine to interpret that. And then maybe you don't agree with the AI, and that's fine, but at least you'll have an understanding of why something was recommended.
Right, yeah, and just to build on that, I mean, that's one of the things that we're consciously building into our system as well is that it is fully explainable, because in research labs at universities, they're still holding a lot of these AI tools at arm's length, and it's because of this black box nature. You know, you use AlphaFold for protein folding, and it gets it right or whatever, but it gives you like a score of 9. Well, it's not defined anywhere. There's no rubric. You can't even Google it. What does that mean? A scientist can't file that with the FDA with their IND filing, right? And so we've built our system again, you know, around like the knowledge graphs as well, to actually deliver a nice report that would be something that would be compliant with the FDA, that a scientist could actually submit with their IND filing, so that they don't just say, oh, I used AI and this was the answer. It's like, no, this is the actual mechanism that gave us the result.
Yeah, I think it's a great point. There's two things there. There's one, how do we build AI that works well with physicians so that they can explain and go through a process and really make a better assessment of whether that recommendation is grounded in truth or not. And I think there's also a part on the physician that has to change the way that they work a little bit, not fundamentally, but to leverage the power of that AI and understand how to work in that symbiotic relationship so that they are augmented by each other.
Yeah, absolutely. And so back to the question that you asked, you know, some of the onus is on us to develop better tools and, you know, but physicians also need to undergo training in medical school about, you know, how to interact with AI. You know, this idea of prompt engineering, if you've ever played with ChatGPT or read about it, you know, this is a very common phrase that gets tossed around. I am sure that my nieces, for example, you know, they were born into this AI age. To them, asking questions of ChatGPT is going to be just as intuitive as navigating an iPhone is to me, whereas neither is particularly intuitive to my mom or dad, right? And so, you know, it will become more intuitive as these technologies exist and are more pervasive, but in medical school in particular, I think there's going to be a need for educating on specifically how to interact with these tools, because they are very powerful, but you know, there's a certain amount of learning curve, and sure, there's guardrails implemented, but the guardrails don't necessarily facilitate the best and most effective use of these tools.
Right. And I think it's interesting to think about also what data to focus on, because there's so much data that can be gathered. Now we know with the wearables and with obviously all of the healthcare records that are already available. But for people who haven't necessarily been collecting that data or looking at it, and would like to start, or where's the most gain going to come from in terms of data points that can be collected and looked at over time?
So I think it's a great question, because we assume AI is a solution to prevent, you know, in this longevity sphere we're talking about, is AI going to be the solution which is going to increase, you know, improve our health span? And from that angle, let's assume when a person walks in, AI is not going to help you address what has happened in past. AI is going to be something which is going to make things better in the future. And if the training data set is very personalized and able to extract the right information, we would actually know what features to monitor. Right. Sometimes people just wear a bunch of things, which when we want to cheat, we just cheat it aside. So that data sanctity needs to be built into the architecture of a person's thought process. That look, if this is what I'm going to fix, because most people actually, when you walk into a clinic, there is some underlying medical problem which they want to be fixed. They're not walking into for a longevity intervention. Because those who do longevity, they do too many changes and too many variations, so that makes things very complicated. But from a healthcare practitioner, you need to meet the need of a person who walks in with some problem, you fix that, and then you give them certain things to record, which they can be variables or can be tracked over time to understand how they respond to change in the body. That's where the AI would help you decide what features, what parameters would be most useful for this particular individual or this particular problem in their life. And that's where the big win will be coming.
Yeah, I don't know if any one of you want to add to that, but I think it's important when you start from the ground up to prioritize a few things, because like you mentioned, you can't just look at everything from the start. It's important to pick a few key things that you can get started with to get the most benefits.
Well, yeah, I think, starting with a couple of data points, like your sleep or, how much exercise you get and seeing how that affects various components, it might encourage people to start collecting more data. I know I'm always interested in looking at my Aura app of how did a late meal affect my sleep and what I should avoid for that, and how much activity affects the quality of sleep I get. And I'm a scientist, so of course I find this interesting, but it's also motivating for other people to start to, out of curiosity, see how that's affecting them. So I think it's good for forming those habits. So.
Right, and it's nice also to, there's a dual benefit, I think, to this data. One is the data itself, that it really gives you insights as to what you're doing, how it's working, etc. And I think the other benefit of measuring something is also the behavior change that it drives, right? Because I know this from personal experiences. As soon as I started, wearing the ring, for example, the Aura, which is what I use, but and the Whoop now, I pay attention to this because I know that eventually I will be confronted with that data, and so it's driving behavior change. What do you guys?
Well, and behavior change is probably the hardest part of everything we're doing. Is the last thing that I mentioned in my talk earlier is we all generally know how to be healthy, and yet we don't do it anyway. Yes. Maybe there's limitations on it. It is often more expensive to eat healthy, not to mention sugar is delicious. But and so there's access issues and all of these kinds of things. But it's also just the awareness of I was telling you earlier, when I started wearing my wearables, I just had in my head oh, I'm in bed by 10 p.m. every night. That's a lie. I'm definitely not. Yeah. Right. And so just having the awareness of the data did help me make the behavior change, and helped me be a little more conscious about, okay, I'm actually going to go to bed, I'm going to implement a routine, et cetera, and not just for sleep, for exercise as well, and eating habits, all of that kind of stuff.
Yeah, definitely. And I want to quickly shift focus back to the importance of data and the quality of data to really understand how we can move forward in Mauritius, because, and Deepak, this one is really for you, how, in India, you've also help develop data that is more appropriate for the population there, and that can help provide better recommendations and outcomes and diagnostics. So how do we, in Mauritius, start to either collect that data, or do we have to work with partners outside, or how does the country can really,
So I can tell you from the experience which we've had with Longevity India, which we're doing data collection, I think it's a pretty complex problem to collect data. So it's always a good idea to deal with people who have an expertise. I was just talking to him that we have data and we are struggling to figure out the tools for visualization. And he's got the right arsenal available with him. So there's no reason for us, I think, given the globe has become smaller now, people are talking to each other, we can always learn from the other people's learning. We don't have to reinvent the problem and try solving it. So, but I think the ultimate truth is that data is the king. You need data for any type of decision making, which is more or less, in real sense, is hyperlocal. So I need your genome. Genome is a draw of hands which we had no control on. It's just something which you got. But phenome is something which you control. That means it's your body and how it interacts with the environment. Then we need data of environment also. So let's say if you report with to a hospital about certain issues, I need the information where you are coming from. I need that geographical location to know about the air quality index, if there's certain local problems and that. So that decision-making process now with multiple data feeds which we're getting from multiple sources can actually improve clinical decision-making. And that way we need to figure out what kind of data you need to collect from me, which means my genomic data, which is basically my blue book, which is hardwired. I know what I can metabolize, what I can't metabolize. Then I need to know where I come from so I understand the geographical contribution to my health. And the last is my current health. And that data is dynamic. Right. So we need to, using AI, to figure out what is the dynamic data, how much is the minimal data set which we can collect, and tie in with your genome and the environment exposome, and then go about building the infrastructure. So I think that is something which in a country like Mauritius can definitely do, to start tying in these different dimensions and build an integrated database where you keep the data, stays with you, and you can do something which called the responsible data sharing through a data lake and with federated learning. I think that fantastic stuff can be done here.
Definitely, and we were just talking with Kennedy actually before how there's a unique opportunity in Mauritius also, well, not necessarily unique, but we have access to our own medical data at our own will, right? And that's something that in other countries like the United States, for example, is much more complicated to get access to your own medical records. So people are really empowered here to actually gather that up and take action on it. Now, obviously, as we mentioned, it's better if it happens on the healthcare system side rather than people taking it literally into their own hands. But I just want to wrap up with, we've been talking, to wrap up the panels where things go in 5 years, and I'm just curious to get each of your thoughts on this. So what does a typical trip to the clinic look like in, let's say 2030, as we've been saying, in regards to AI and the physician, and what does that journey look like?
Let's start from there.
Yeah, so I envision going to the clinic, still seeing a human. Maybe that person receives slightly different training than they do now. There is an AI that helps visualize and interpret. Maybe it delivers an action plan that's personalized based on all of the data. And then I have a conversation with a human, and we talk through, all right, the AI said this, and I can tell you right now, I'm not going to do that. I don't, I'm not just going to I'm going to, only eat vegetables for the rest of my life, whatever it is, And so there's still going to be interaction, but to me, the promise is there's just way more data involved, because too often when I feel like I go to the physician right now, data is not actually really being captured. I've tried giving my PCP, my aura data, my genomic data, all of this, and I just kind of get a pat on the head, and that's cute. I'm going to go back to the tools I use, right? And so really, to me, I just want it to be data-driven. I want more data.
Yeah, very nice.
Yeah, I agree with what James said. I'm looking forward to more personalized experiences at the physician level, and especially as a female, I am looking forward to a lot more data. I'm hoping for more women's health data. A lot of studies out there for recommendations for women's health, and I saw this very clearly when I was pregnant with my 2 children. A lot of those studies and recommendations are based on something like, oh, well, we did this study on some rats 50 years ago, and all those rats were male. So I'm looking forward to more data on that, more personalized data on and recommendations, especially as it pertains to, we know cardiovascular health for women is different. Metabolic health is very different, obviously. There's the hormone replacement therapy question, and that's just stuff that people go back and forth on their recommendations for, just because we don't have a lot of data on female health when it comes to that stuff. So I'm looking forward to better answers for that But yes, I also know that there will be a human in the loop, and hopefully the AI will also allow for more time to connect with a physician instead of just having like, the 2 minutes passing like, oh, hi, how are you? Like a physician can actually sit there and talk to you about your results, and the AI will give them some of that time back.
Definitely.
So.
Interesting takes. I see the visit into clinic in maybe 20 years down the road will have AI and non-human on both sides of the spectrum, and maybe human in the middle. The way I see it is maybe when you walk into a clinic, there'll be a whole bunch of tests which would be streamlined without human intervention, maybe from a droplet of blood and some non-contact recording, which will actually give a clinician a pretty good overview about where you stand today to make a clinical decision making or understand what's bothering you. So that's a human in the loop. And then it goes downstream in terms of management of that person's health, and that will be largely driven by wearables. And if there's somebody who's got a chronic condition, maybe wearables which are sitting inside the body, not just on the body, which give you real time, like CGM. So if somebody's got a metabolic disease, a CGM gives a very beautiful quantum of data which helps decision making. So I think that kind of transition might happen. We would have CGM-like devices for more chronic disease management, but also upstream they would be less invasive, less intrusive recording of an individual, and that clinician will sit in the middle and then take a call about your health in a much more meaningful way. As you said, you would like to know what the data is trying to tell you. So this guy's largely is going to be data interpretation, but also the clinician understands biology to a certain extent.
Yeah, I think that the common theme here is that visit has to be more data-driven, right? And I think this is really something that would add a lot of value to be able to not just rely on the data and what it can provide in terms of insights, but especially to look at the trend and the evolution of those different data points over time. So thank you.
Thank you.
And thank you everyone for listening.